So today we're going to be talking about the new PT and OT evaluation codes for 2017. Now, first of all, let me give a disclaimer. Because I'm a physical therapist and I'm very familiar with all the background materials and practice-related materials for the practice of physical therapy, we're going to get a little bit more detail on the PT evaluation codes than I am personally able to do for the OT evaluation codes. The AOTA has a webinar that's free for AOT members. It's about an hour and a half long, and you can also do check into that if you feel like you need more detail and don't understand some of the terms related to the practice documents that the AOTA refers to. So let's first remember that the PT and OT evaluation codes have been, up to this point, different from each other. They're actually valued differently. And you'll find in the new codes that there's significant difference in the definitions of the evaluation and reevaluation codes for the two different disciplines. There are no changes in the speech codes for this year. Speech has had quite a few changes over the last few years, and so there were not any changes in the speech codes for this year. So up until January 1 of 2017, we will continue to use the PT and OT evaluation codes we've been using for years, so that's 97001 through 97004. However, starting on January 1st, we will be using new evaluation codes. The way that RevFlow is set up, we will only make the old evaluation codes and old reevaluation codes possible to use on payers who are requiring it. I don't expect there to be very many of them. It's a low-risk transition for the payers, as we'll talk about in a little bit, because of the way that CMS has decided to do the fee schedule amount for the evaluations. So I think the first question to ask is, why do we need new evaluation and reevaluation codes anyway? Well, this is primarily being driven by a change in the law that happened back in 2007, which basically requires CMS to move away from fee-for-service fee schedule payment and therapy cap. And the only way for the therapy cap to go away is for Medicare to change the payment system to an alternative payment system. Now, that's been a big agenda within CMS for several years, right? It started with BQRS. Then it was the value-added modifier for the physicians, and then the physicians are transitioning to the MIPS program in 2017. It's likely that PT and OT will transition to MIPS in 2019. So we have a couple of years yet before we're pulled into that system. But the new evaluation and reevaluation codes basically open the door to treatment based on intervention strategies that are based on patient severity and the complexity of clinical decision-making. This will open the door to either new intervention codes that take severity and complexity into account, or possibly even episodic payment alternatives, which would be something like outpatient DRGs, but that remains to be seen what will happen. So the PT evaluation codes, which go into effect on January 1st, there's 3 levels of evaluation codes, and the level is chosen dependent on the complexity of clinical decision-making and the severity of the patient's condition. Together, these 2 elements determine the level of service. So the level of evaluation will be low, moderate, or high complexity. So the actual codes for the new evaluations are 97161 for low complexity, 97162 for moderate, 97163 for high complexity evaluation, and then the reevaluation code is also changing to 97164. So now what we're going to do by PT and then by OT is go through the new codes and what the requirements are for the codes. Now, the evaluation codes for OT is the level of OT evaluation, again, is determined by patient condition, the complexity of clinical decision-making, the scope and nature of the patient's performance deficits relating to physical, cognitive, or psychosocial skills that will be assessed in the evaluation. So you can see that the determining factors for what you are choosing are significantly different between the two different disciplines. The evaluation codes for the new OT codes are 97165 for low complexity, 97166 for moderate, 97167 for high complexity, and then the OT reevaluation code is 97168. So the way that CPT codes get into fee schedules is via the relative value assigned to the codes. And relative value, of course, has provider work component, practice expense component, and malpractice or professional liability component. Now, the process is once the codes are defined, then by the AMA CPT editorial panel, they then go to the RUC, which is the RVRVS Update Committee, and the RUC then values the codes and then submits those coding, takes the values that they come up with for the relative value of the codes and submits those to CMS. CMS has three choices. They can accept them, they can reject them, or they can change them. So what CMS decided to do, and we know for sure when the final rule came out at the beginning of November, that the work values for the PT and OT evaluation and reevaluation codes will, or I'm sorry, just the evaluation codes will remain unchanged from the current codes. So that means there's not going to be any payment difference between these three levels of evaluation. Now, I know at first glance this seems like a bad thing, but I think it's actually a good thing. It will give us some time to learn how to use the codes appropriately, and the payers have to learn how to look at the codes appropriately also. So it's not just a provider learning issue, it's also a payer learning issue. Because what the payers are worried about is what they have with the physicians, right? The physicians have their evaluation and management codes, and the big problem there is always upcoding. So it'll be low-risk implementation for the payers in 2017, and they'll be able to collect data, and we'll be able to concentrate on using the codes correctly. The reevaluation code values, CMS relented and is increasing those in 2017 compared to the current reevaluation code provider work relative value. So just like the old evaluation codes, the current ones, the new codes are untimed, and they're bundled to include all the assessment activities you perform that day, any tests and measures you do that day, any communications that are required about the patient, whether that's external, talking to a physician or a case manager, or internal, talking to staff like an assistant who may be doing part of the treatment. That includes any medical records review you do and any documentation time, and also the production of the plan of care would be included in that. You can typically bill for treatment the same day, but you cannot bill for other tests and measures in the same day. We'll talk about what the other possible tests and measures are later in the presentation. So let's step through the PT evaluation codes, then we'll step through some detail on the OT evaluation codes. So I think the first thing you need to appreciate is if you look at the code book for 2017, there is a full page and a half worth of criteria around these new codes. So there's a lot of spelled out requirements. Now I think that the thing we need to remember here, and I'll be reminding you throughout the presentation, is that the elements that we have to document are not things that we haven't taken into account before. It's just things we haven't typically paid attention to documenting before, and you'll see some examples of that soon. So the major elements that are included in the PT evaluation codes are the patient history, the examination with the development of the plan of care, and includes coordination, consultation, and collaboration of care with physicians and other healthcare professionals or agencies. So the PT evaluation minimum required elements that must be documented are the patient history, the examination itself, the clinical decision-making around the intervention plan that you're putting together, and your assessment of the severity of the patient's condition. And then finally, this is all summed up in the plan of care. So those are all required elements of the evaluation. So for those of you who have only done plans of care for Medicare patients, that ends January 1. All of your patients will have a plan of care. Now, not all of the plans of care for every payer need to be sent to the physician for signature. That's only true of Medicare. But all of your patients should have a plan of care. So let's look at some definitions within the PT examination realm. So when the CPT descriptors talk about body regions and systems, they're defined as follows. So body regions would be the head, the neck, the back, the lower extremities, the upper extremities, or the trunk. Body systems would be musculoskeletal, neuromuscular, cardiovascular, or integumentary. Review of body systems would include the musculoskeletal system, which would include assessment of gross anatomy, gross range of motion, gross strength, height, and weight. Neuromuscular system would include general assessment of gross coordinated movements, for example, a balance, quality of gait or locomotion, transfers and transitions, and motor function, so motor control and motor learning. Would also include cardiopulmonary, so assessment of heart rate, respiratory rate, blood pressure, and edema. For integumentary, the assessment of pliability or the texture of the skin, presence of scar formation, skin color, and skin integrity. Now, certainly for many of your patients, you will not have to do a significant deep dive into all the different body systems, right? You will obviously only do a deeper dive on the ones where it's indicated based on the patient's condition or history. The review of body systems also includes the assessment of the ability to make needs known, their consciousness, their orientation to person, place, and time, expected emotional or behavioral responses, and the ability to learn. Now, this is something that we have traditionally always taken into account because we typically treat people who will benefit from treatment, right, because of their cognitive ability to follow instructions, do a home program, and cooperate with the treatment. But now you have to document that, right? So just like the physicians, we're going to be making statements about the patient's ability to be involved in their own care. The review of body systems also includes body structures, so structural or anatomical parts of the body, such as organs, limbs, and their components, classified according to systems. So this would be identification of impairments, things like range of motion, manual muscle testing, arthrokinematics around a joint, ability to move, motor planning, those types of things. And then personal factors. Now, personal factors is a big category. We're going to have a lot to say about this, but these would typically be things that we would consider to be complexities. So factors that include the sex of the patient, the age of the patient, coping styles, social background, education, profession, past and current experiences, overall behavior pattern, character, and other factors that influence how disability is experienced by the individual. So this whole idea of complexities is really critical to being able to assign the right level of evaluation to your patient, because complexities basically determine how complicated the clinical decision-making will be around your patient. So complexities include secondary diagnoses that will affect treatment, as well as other complicating factors. And these are things that can influence the physical therapy treatment. So they'll do that by influencing the type of therapy that you give, the frequency of the therapy, the intensity of the therapy, or the duration of the treatment. They can be represented by secondary diagnosis such as comorbidities, but also other patient factors such as age, severity, acuity, multiple conditions, motivations, or other social circumstances such as the support of significant others, help in the home, or availability of transportation to therapy. So the elements of the PT evaluation are the examination, which includes the history, the systems review, as well as any tests and measures you do to validate and to create a baseline of the patient's functional status. The evaluation, which is the thought process leading to identification of impairments, functional limitations, disabilities, and any needs for prevention that are identified. The diagnosis, which is the impact of the condition on function. The prognosis, which is the professional judgment regarding the predicted functional outcome and the estimated duration of the services required. And then the plan of care, which is actually the culmination of the evaluation and is a summary of the evaluation and examination process itself. So there are 4 components of severity and complexity when it comes to the PT evaluation codes. The patient history, which is the medical and functional history, including any relevant complexities. The examination, which is identification of the impairments, including any standardized tests and measures you do to create a baseline of function. The clinical presentation of the patient, so are they stable, are they changing, or are they unstable? And then clinical decision making, so use of standardized patient assessment instrument and or measurable assessments of function. So we'll go through each of these. So the patient history would include any comorbidities, which would be medical history and or medications that impact function or otherwise might impact the plan of care. So you do not need to worry about comorbidities that don't have an impact on the plan of care. The prior functional level and the context of current functional ability. So do they have the ability to regain their prior level of function, or is the disease or injury significant enough that they will not be able to return to the prior level of function, but you will be able to identify the level of function you think they can achieve? Any past treatment that they've had, if it's appropriate, and any other factors that may impact the ability to reach your goals. And then would include also the social history, living environment, work status, and other cultural factors which may affect the patient's response to treatment. Okay, so the new PT evaluation codes make significant use of the International Classification of Function. So I'm going to give you a brief review of that, and I think that will help tie some of this together because we'll actually look at some examples. So the most critical elements that affect the entire episode of the patient are the health conditions of the patient, and in this sense, condition means the primary conditions that you are treating the patient for. Then any personal factors, that's on the bottom right, which would include any comorbidities, the medications they take, and other things about the patient that may affect the course of care. And then environmental factors, which the patient will need to overcome in order to have a successful outcome. So those 3 main elements of function are going to have an interplay and then affect the things that run through the middle of the diagram. So the things that when you evaluate the patient that you will find will be problems with body structure and function, which we would call impairments. Then activities, which are things that the patient can do, but you'll also be identifying limitations in their activity levels. And then those activity levels coalesce to form participation restrictions, which is the patient's involvement in life situations. So let's look at the definitions a little differently. So again, this is the same diagram with a little bit more information in it. So you have the health condition at the top. Remember, the health condition is really the physical therapy diagnosis. That's what you are treating in the patient. So the elements that are affected are the body functions and structure, which we would call impairments, which would be problems with bones, ligaments, muscles, sensation, circulation, any of the parts of the body that are malfunctioning. Those result in activity limitations. So activities would be things like speaking, walking, jumping, squatting, rolling, bed mobility, those types of activities. If you have enough activity limitations, it will lead to participation restrictions. So remember, that's participation in life events, so things like work, social involvement, athletics, or avocational activities. Their ability to do things at home, the ability to take care of children or other loved ones. So those would be participation restrictions. Now our functional tests and measures, which are either physical performance tests, which typically identify activity limitations, or patient surveys, which are more typically going to reveal participation restrictions, are the elements that we will use to document the functional levels of the patient. Now, things that can affect the outcome of the episode of care would include personal factors, so the patient's age, comorbidities, their personality, other things like that, and then environmental factors, so living conditions, occupational situations, social circumstances, and climate. So those are all things which can coalesce to affect what will happen in the episode of care, how many resources the patient will require to get better, what period of time you'll have to apply those over, and what kind of outcome you'll expect to have at the end of it. Now, the diagram identifies the 3 levels of human functioning classified by the ICF. So at the level of the body or the body part, the whole person, and then the person in the social context. So disability involves dysfunctioning at one or more of these same levels. So impairments affect the body or the body part. Activity limitations affect the whole person, and the whole person in the social context would be represented by the coalescing of a number of limitations that would produce participation restrictions. So in terms of examination, so in thinking about activity and participation, you already have a lot of experience at that, although you may not be thinking about it that way. So if you take what you already know about the ICF from functional limitation reporting, right, because we are using these various areas to document now, at least for Medicare patients, about restrictions and limitations that they have in their ability to function. So we have the mobility category, which is changing and maintaining body positions, carrying and moving objects, walking and or moving around. Self-care activities, which would be personal ADLs, which would be either basic or instrumental ADLs. Domestic life, acquiring necessities, household tasks, and assisting others. Other major life areas like education and work, community, social, and civic life, so things in the community, recreation, and leisure. So clinical presentation is also another way in which you will have to have criteria to determine whether your evaluation is low, moderate, or high complexity. So the question you want to ask yourself, is the patient's condition stable or uncomplicated? Or is it evolving clinically with predictable changing clinical characteristics? So in other words, the condition is changing, but it's changing in the way that you would expect. Then you have evolving clinical presentation with unstable, worsening, or unpredictable characteristics. So this would be a complex patient that is hard to predict how the patient is progressing or what you expect as their condition evolves. So the complexity of clinical decision making is really based on the composite of the patient's clinical presentation in ICF terms. The dynamic interaction between the health condition, which is the primary condition you're treating them for, environmental factors that affect the patient, and other personal factors that will affect the outcome of the course of care. Now, the best way to think about this is to ask yourself a basic question when you evaluate a patient, and that is this: how is this patient with this primary condition, what other factors exist that make this patient different than other patients that have this same primary condition problem? So it would be looking at a person with a meniscectomy who's 27 years old and basically healthy versus a 45-year-old patient who has a meniscectomy who also has diabetes and congestive heart failure, right? They both have the same primary condition, but the 45-year-old has significant factors that are going to make that episode of care fundamentally different than for your 27-year-old with the meniscectomy. So ask yourself the question, how is the environmental and personal factors of this patient going to make this episode of care for this primary condition different from other patients that have that primary condition? So let's look at a patient example, and maybe this will help you understand how to think about this idea of the interacting play between the various aspects of the patient. So we're going to say that we have a 32-year-old woman here who has a knee with and patellofemoral joint injuries. So her impairments are she has limited stability of the patellofemoral joint. She's got diminished quad strength. She's got pain in her anterior knee. She's got impaired structures of the knee and leg and limited knee mobility. Now, those impairments lead directly to a couple of important limitations for her. So she has limitations in walking long distances, so she can't walk long distances. And she's limited in climbing stairs and squatting, jumping, and running. So those activity limitations lead to these participation restrictions in her life. So she's unable to participate in recreational activities, and she's unable to complete her graduate work. Okay, well, wait a minute. Why is that? Well, if we look down at the environmental and personal factors, we see that she's going to graduate school in Boston, and in the winter, they have snow and ice, and walking is her primary method of transportation. So those are very important environmental factors affecting this patient's condition. If this patient were going to UCLA and had a car, these might not be as important to her episode of care as they are to her in Boston. Now, her personal factors are to our advantage, right? So she was recreationally active before her knee injury, and she's knowledgeable about her condition. It seems like anybody with a computer is as knowledgeable as we are about their pathology, or at least they think they are. So you can see how the primary health condition at the top, how that episode of care is affected by the environmental factors as well as the personal factors being experienced by the patient. Now, for this patellofemoral pain example, you want to pick the right measure to measure her functional level, one that's valid in the patient population that she represents. So in this particular case, we decided to use the lefts. So her initial score on evaluation was 52 over 80, and after 3 weeks or 7 visits, she was at 72 over 80. Now, this whole idea of picking tests and measures that are valid in your patient population is very important. For those of you who feel like you need some help with that, I can refer you to ptnow.org. This is a website that's put up by APTA, and the input to that website is from the different clinical sections of APTA, where they're going to talk about suggestions of measures that are valid in patient populations represented by those clinical sections. So that could be very helpful to you to identifying either physical performance tests or patient surveys, which will be effective at measuring your patient's functional level. Now, there is time guidance related to these 3 evaluation code levels. And by guidance, we mean just that. The wording is lifted directly out of the CPT code. So the time is guidance only and not to be used in the sense that we think of time for our 15-minute procedure codes. So they say low, the face-to-face time with the patient will typically be 20 minutes. That doesn't mean it has to be 20 minutes. It doesn't mean that it can't be more than 20 minutes. It doesn't mean that it can't be a little less than 20 minutes. Moderate is typically around 30 minutes of face-to-face time, and high is typically 45 minutes of face-to-face time. Now, time will be most helpful to you if you are having trouble deciding between levels of evaluation, and you're looking at the clinical decision-making and the stability of the patient's condition and all those things, and you find that you spent 50 minutes with the patient rather than 35 minutes with the patient, then that might help you opt for the more complex evaluation code. But I want to emphasize these time elements are not in the same sense of the time that we use in the 8-minute rule relative to the 15-minute procedure codes. Because the PT and OT evaluation codes are still considered untimed codes. So here's a grid that's laid out for the 3 levels of PT evaluation. So for history, the criteria are no personal factors and no comorbidities that impact the plan of care. So simple, straightforward, you're treating the primary condition and not having to take other things into account. The examination would include body systems for standardized, using standardized tests and measures for 1 or 2 elements of body structure and function, activity limitation, or participation restrictions. So the elements of the examination are the ones that are easiest to achieve for each level of evaluation, and we'll see examples in a few minutes. So is the presentation stable or uncomplicated, right? So if it's stable or uncomplicated, then it's got a low complexity evaluation. The clinical decision making is low complexity, utilizing standardized outcomes tests and measures and measurable assessments of clinical outcomes. So you have to meet the elements required in each of the 4 categories in order to reach a decision on which PT evaluation to pick. So for example, if your patient must have just a simple condition, you've got to be looking at 1 to 2 elements. It should be stable or uncomplicated, and you're typically probably going to be using 1 measure. Contrast that with the moderate complexity evaluation. So now under history, you see they've got 1 or 2 personal factors and/or comorbidities that impact the plan of care. The examination is using standardized tests and measures from 3 or more elements of body structure and function, activity limitations, or participation restrictions. The presentation is evolving. So it's changing, but with predictable clinical characteristics. So not as simple as the low complexity patient, a more complex problem, but the patient is presenting with an evolving condition that you would find to be predictable based on your knowledge of the pathology. And then the decision making for moderate complexity using standardized outcomes, tests and measures, and measurable assessments of functional outcomes. So, excuse me, the high complexity PT evaluation then for history is 3 or more personal factors and/or comorbidities that are in fact impacting the plan of care. The examination would include body systems using standardized tests and measures from 4 or more elements of body structure and function, activity limitation, and participation restrictions. The presentation needs to be unstable, unpredictable clinical characteristics. So not what you would necessarily expect and difficult to predict. That would make the clinical decision making high, again using standardized outcomes, tests, and measures to support your position. Now, there's a big change in the PT Reevaluation Code. So prior to January 2017, we could use the PT Reevaluation Code for a number of things other than working up a new problem on a patient. But now, by definition, there is a single complexity level for the Reevaluation Code, and you can only apply it where there is established or ongoing plan of care. So if you're seeing a patient with a problem and they come in with a script for another body part or another condition 2 weeks into the episode of care, today you could use the Reevaluation Code to look at that new problem and create a plan of care for it. Not anymore. So if your patient comes in with a second condition now, you're going to pick one of the 3 evaluation codes to work that condition up, and it will result in a new plan of care. So you can only use the Reevaluation Code on an existing problem with an existing plan of care. It requires an examination including a review of the history and use of standardized tests and measures. It requires a revised plan of care using standardized patient assessment instrument and/or measurable assessment of functional outcome. And typically, it will have 20 minutes of face-to-face time. Now, don't be confused about the fact that you assess the patient every time you see them, but that assessment period for each time you see the patient is part and parcel of what you bill each time you bill a CPT code. So that face-to-face time for that assessment that you do with the patient must reach around 20 minutes in order to bill for a reevaluation. And then you would also reflect that by having an updated plan of care. So you can't have a PT reevaluation without a change in the plan of care. The plan of care would typically change by a change in goals, because your patient's either getting better more quickly than you anticipated, more slowly than you anticipated. So one of those two things is going on, and your long-term goals for that episode of care will change as a result. So let's look at a couple of patient case examples. So here's example one. We're going to look at two different examples. So in this particular case, we're going to say we've got a 40-year-old male with a 3-year history of low back pain. It's been increasing in frequency every month or two, from being affected by it every month or two to being affected by it daily over the last 30 days. So the BMI measurement is 33, which would be high compared to the normal range. Pain worsened over the last 30 days from 3/10 to 8/10. Their oswestry is 35. Their work has been interrupted 3 times in the last 2 weeks, and standing is limited to 5 minutes before they have an onset of pain. They're waking up 3 times per night due to pain. So how does this break down into our 4-column structure? So in terms of history, we have a BMI that's positive for being overweight, and they have increasing frequency of pain. In the examination, they have work, standing time limitations, sleep interruption, and then you've got your trunk exam that you would be doing. Their presentation, it's an evolving clinical presentation. The patient is not stable, but it's evolving in a predictable way. We'll say the face-to-face time for the evaluation was 35 minutes. The clinical decision-making then is moderate, so you would pick code 97612 for the moderate PT evaluation code. Okay, so we've got at least 2 personal factors, right? They had got a positive BMI for overweight, and their frequency is increasing. As I said earlier, typically the examination is the easiest place to get, for moderate, we need 3 to 4 things within body structure and function, activity limitation, or participation restrictions. The presentation's evolving because its pain is getting worse, and the face-to-face time is what it is, so that makes your clinical decision-making moderate. Let's look at another patient case. So this is a 67-year-old male with a 6-month history of neck pain with pain and stiffness of the right shoulder. Pain has been decreasing over the last month for the shoulder, but stiffness has been increasing. The MRI was positive for a C5-6 disc problem. He has poorly controlled diabetes mellitus. He has BMI of 35, a history of COPD. He has limited ability to do self-care because of his shoulder limitations. He can't carry objects with his right arm due to pain and weakness. Can't do yard work or vacuum. His neck pain and disability index is 25 out of 50, which is borderline between moderate and severe, and his DASH score was 69.2. So when we break this down, we've got 4 personal factors. He's got a positive MRI. He's got a positive BMI for being overweight. He's got 2 comorbidities in COPD and diabetes mellitus. His examination, his home ADLs are affected, his ability to carry objects is impacted, neck pain and disability index, the DASH, you're going to examine his neck and his upper extremity. So no problem meeting the elements for highly complex for the examination. The presentation is clearly unstable, and his symptoms are worsening, and they're changing in unpredictable ways. We'll say the face-to-face time for the evaluation was 50 minutes. So in this case, we'd say the clinical decision-making was high, and we would build a high complexity PT evaluation code 97163. So before I go on to the OT codes. Let's see if there's questions that we want to answer at this point, or we can always circle back again at the end.
Just a reminder to everyone, you can type in your questions in the question box, or you can raise your hand and I will unmute your line to allow you to ask your question.
So we don't appear to have any questions at the moment, so we will spend some time addressing questions at the end. So let's look at the OT evaluation code. So the OT evaluation codes, and you'll notice this is significantly different from what we talked about in PT. You have to do the occupational profile and client history, which includes medical and therapy history review, assessment of occupational performance, clinical decision-making, and development of the plan of care. So definitions related to the OT examination. So performance deficits would refer to the inability to complete activities due to lack of skills in one or more of the areas below. So physical skills, which would be impairments of body structure and function. Cognitive skills, which are ability to attend, perceive, think, understand, problem solve, remember, or ability to organize occupational performance. Psychosocial skills, so interpersonal interactions, habits, routines, behaviors, and coping strategies. There's time guidance for the OT codes too. They're a little bit longer than for the PT codes. Again, the time guidance, the time is for guidance only and should not be thought of in terms of how we think about time for the 15-minute procedure codes. So a low complexity OT evaluation is typically 30 minutes of face-to-face time, moderate is 45 minutes of face-to-face time, and high is typically 60 minutes of face-to-face time. So 97165, the low complexity OT evaluation code, includes a brief history including review of medical and OT therapy records for the presenting problem, assessments that identify 1 to 3 performance deficits relating to either physical, cognitive, or psychosocial skills that result in activity limitations and participation restrictions. Then low complexity that includes analysis of the occupational profile of the patient, the analysis of data from problem-focused assessments, and consideration of a number of treatment options, a limited number of treatment options, no comorbidities, and that no task modifications or assistance were required to complete the evaluation components. Now for the moderate complexity OT evaluation, they have a brief history including expanded review of medical and/or OT therapy records for the presenting problem, assessment of 3 to 5 performance deficits, so definitely more performance deficits relating again to cognitive, physical, cognitive, or psychosocial skills. Then you have moderate analytic complexity that includes analysis of the occupational profile, analysis of data from problem-focused assessments, and considerations of a limited number of treatment options, but may have comorbidities and may have minimum to moderate task modification or assistance required to complete the evaluation component to meet the moderate complexity OT evaluation. 97116 is the high complexity OT evaluation. It includes a brief history including extensive review of medical and/or OT therapy records for the presenting problem, assessments that identify 5 or more performance deficits relating to physical, cognitive, or psychosocial skills resulting in activity limitations and participation restrictions. And then high analytic complexity that includes analysis of the occupational profile, analysis of data from the problem-focused assessments, and consideration of an increased number of moderate options, of treatment options, definitely has other comorbidities, significant task modification or assistance was required to complete the evaluation components. Just like with the PT reevaluation, the OT reevaluation applies to a patient with an established plan of care with the following components: assessment of changes in the patient functional and/or medical status with a revised plan of care, update initial occupational profile to reflect the changes in the conditions or the environment that affect the future interventions and or goals of the patient. A revised plan of care, formal reevaluations performed when there is a documented change in functional status or significant change to the plan of care. So those are always reflected by changes in the long-term goals for the episode of care. Typically, the face-to-face time for the OT reevaluation is 30 minutes. So this whole idea around evaluation, whether it's for PT or OT, is a change in the plan of care which would be reflected in a change in the long-term goals. Okay, I want to take a few minutes and review assessment codes and how the assessment codes interact with the evaluation codes. So these are not changes that are coming in 2017, but I thought it would be good to review that because I got a lot of questions around the assessment codes. So first of all, let's think about some definitions. So assessment is separate from evaluation and reevaluation. So evaluation and reevaluation are separately billable services. We've just spent the last 45 minutes talking about how we do that. Assessment is a component of each billable intervention or treatment that you do, and is generally not separately billable. Now, there are test and measures codes, and we're going to talk about those. Both evaluation and assessment are only provided by clinicians who are therapists. Assistants can only do assessment within their scope of practice and can never do evaluation or reevaluation. So there are some assessment interventions that are separately billable, and we're going to look at those now. So the first thing you need to remember about the separately billable assessment codes are that only one evaluation can be done per day per discipline. So if you have a patient who comes in with multiple problems, then you would be looking at a moderate or high complexity patient. You would not be doing two moderate complexity evaluations on the same patient within PT or OT. PT and OT can each have their own, and they can be at different complexity levels, but you can't have multiple PT evaluations or reevaluations or multiple OT evaluations or reevaluations in the same day. Assessment, the billable assessment codes and the evaluation codes cannot be used on the same day because the evaluation codes are bundled to include all the assessment tests and measures you do that day with that patient. Multiple assessment codes can usually be billed the same day with each other, and you can typically bill for assessment of treatments in the same day, just as you can usually bill for evaluation of treatment in the same day. So I think that'll become more clear when we actually look at the code. So the first code I want to talk about is the physical performance test or measurement code. So this is a test for measuring standardized elements of the patient. So this is a 15-minute code that is used for standardized testing. So this would be standardized testing as validated in the professional literature. It would not include range of motion and manual muscle testing, which are not standardized measures. We would typically use this code on the day where we're doing repeated testing for functional limitation reporting or for the Medicare progress report, which we do every 10 visits. Assessment tests are separate and distinctive from evaluative procedures and from the range of motion test and measurement codes. So examples of these would be like your computerized testing, like the Biodex or the B100. Then you have the physical performance test, like the Berg balance test, the Tenay's test, the TUG, any of those, the Sims-Weinstein test, volumetric testing, and then you have the patient survey tests, so things like the Oswestry, the Leishman score, the DASH, the Neck Pain and Disability Index, or the LEFS. Would also include things like developmental screening, like the Denver Developmental Screening or the Bailey. So these all require a separate report. So if you do a test like this, you would be reporting the outcome of that test in the medical record. But remember that you do not bill this as this code the same day that you would be billing for evaluation and reevaluation. This would be for doing follow-up testing. For example, because you were going to do a report to the physician and you wanted to repeat your functional tests in order to do that report to the physician, that would be a much better code to pick, for example, than the reevaluation code because it pays significantly more. The physical performance test and measurement code pays up in the mid-30s depending on the exact payer for each 15 minutes. So if you were to do 2 different functional measures, then you could use the time it takes to do that. So let's talk about that. Now, for the physical performance test, the time you spend doing the testing with the patient, as well as the time you spent scoring it, reviewing that score with the patient, and the significance of that score to the patient's condition and their progress towards their goals, you should be reviewing that with the patient each time you give them those tests. So you would count all that time and then look at the 15-minute code and see how many units you can build that, depending on how many tests and measures you use. Now, for patient surveys, it's a little bit different. You can't bill for the time that the patient is filling out the survey unless the patient's unable to do the survey themselves and you have to sit there and do it with them. Then you can capture that time. Otherwise, what you would be doing is scoring the test. That's billable, explaining the outcome of the test to the patient, and again, the significance of the patient's change in score to your clinical decision-making about what you're going to do with their treatment and how they're doing relative to their plan of care goals. So that's how you divide the time up. Physical performance test is a little bit more straightforward. For the patient surveys, you don't count the time the patient's taking the survey unless you have to actually give them the survey because they can't either manipulate the device or because they don't understand well enough to do the survey by themselves. We also have the manual muscle testing codes as well as the range of motion test and measurement codes. Now, these codes are untimed, but you can build multiple of these codes depending on what you're actually testing. So, for example, in looking at the manual muscle testing codes, you'll notice that 95831 says manual muscle testing with report for an extremity. So if you were doing the left and right extremities, you would be billing 2 units of that. If you were including both hands, then you'd be billing 2 units of 95831 and 2 units of 95832. Now, what you need to remember is that when you use the manual muscle testing or range of motion test and measurement codes, you must include the major components of movement at each joint in whatever you're referring to. So, for example, if your patient has a total knee and you're watching their knee extensor lag, you may conclude that it's worth the time to measure, report the manual muscle testing and range of motion at the hip as well as the ankle and the foot, or you may conclude that it's better just to measure the knee and include that time in your assessment and management time for the other interventions you're billing that day. So you'll notice that for manual muscle testing, it includes the extremity excluding the hand or the trunk. So in manual muscle testing, the trunk is treated as 1 unit. In 95851, the range of motion measurements of the report, again, it's each extremity excluding the hands or each trunk section, which would be cervical, thoracic, or lumbar. So different for the manual muscle testing for the trunk. In range of motion, there's 3 sections to the trunk. In manual muscle testing, there's going to be 1. Again, you would want to include each of the joints with its major planes of movement for range of motion measurement, and you need to report those codes either in a separate written report or as part of your daily note that day. Remember, if you were going to be doing range of motion and manual muscle testing for both upper extremities excluding the hand, you'd be billing 2 units of the manual muscle testing code, 1 for each upper extremity, and then 2 units of the range of motion measurement code for each extremity. Now, these codes are not intended to be used indiscriminately or often. They would be used in situations in which you were going to be assessing the patient either because of a report to a referring physician or to someone else who requested that report. So this would be something that would be done periodically. They would never be done each visit. So remember, for the manual muscle testing and range of motion codes, do not bill the same day as the evaluative procedures. You can bill with treatment. You can bill with the assessment codes. You can require a detailed, you need to report all those measures either in the daily note or in a separate written report.